Elderly patient with the diabetes. So we'll move on to the elderly. 86-year-old, type 2 diabetes for 42 years, is on glycoside and metformin combination. So glycemic control was good. See, 86 years, 42 years of the diabetic life, glycemic control is good. That is there. Some people, even after 30 years or 40 years, 50 years, they are with the diabetologist only. That means they are not getting any complications so far. So that should be your goal. Your goal is that whenever you see a diabetic, he should be under your care only. He should not move to the hands of a cardiologist or a neurologist or a nephrologist. He had a fall following a slip at home. Fractured neck of the femur is very common in that age group. Underwent hemiarthroplasty. Didn't require insulin or OHA in the intraoperative period as he had recurrent hypoglycemia. His activities were restricted and food intake was reduced. Later on, his blood glucose levels are found to be under control with half the dose that he required before. He is stable. So what advice would you give to him? What is the working diagnosis? Working diagnosis is type 2 diabetes of 42 years in an elderly male. So about 86-year-old male had a fracture of the neck and operated, and he was so far good management on OHS, or glycoside and the metformin. Now he is getting hypoglycemias and he is not on insulin therapy, and his drugs are also reduced to the 50% doses to control his blood sugars. So what advice would you give to him to stop further hypoglycemias? Good. Stop using glycoside. Instead of reducing the half doses of both the drugs, you stop one drug totally. The drug has to be stopped here is glycoside. And you continue the metformin, and as the other doctor is saying that, respect the renal function. So see the urea to creatinine, because the elderly, 42 years of history. So see the urea to creatinine. If the urea to creatinine are elevating, so then better to stop metformin also, because according to the GFR, when the GFR is less than 30, if the patient is on metformin, stop. If you want to start, don't start. If the GFR is above 60, continue. If the GFR is between 30 and 60, reduce the dose of the metformin. Reduce the dose of the metformin. That 30 and 60 you should remember as far as the metformin is concerned. Okay, so get the creatinine done and then get the GFR, and according to the GFR you can adjust the dosage of the metformin. So first rule here is stop using glycoside. Presence of other underlying comorbidities, likelihood of the polypharmacy and the drug interactions, I told you. So a lot of the elderly population know. So they must be also having other comorbidities like that. Possibility of a long duration of diabetes, the attendant complications. Impaired physical and cognitive functioning. So Alzheimer's, dementia, Parkinsonism. So these are all very common in elderly population. So that also you should respect. Not all elderly patients with diabetes have these problems. What is the treatment targets in the elderly patient? Older adults who are functional, cognitively intact, and have significant life expectancy, like our Chandrababu Naidu or like our Modi. So they are very elderly population, more than 75 years of age group, but they are very fit. The cognitive function is so good. They should be treated using the goals developed for the younger adults. So don't always give a lot of priority to the age. So some people know, even though they looks like 80, so their activity, everything is like just like our 60 or 50-year-old fellows. So in such individuals, you have to respect the activity of this population. Glycemic goals can be relaxed and individualized for patients not meeting the above criteria. This is a very important word, individualized. So treatment must be individualized. Okay, the targets or the guidelines are there to guide us, but the treatment must be always individualized. De-intensification of the complex regimens is recommended to reduce the risk of the hypoglycemia and the polypharmacy, if it can be achieved within the individualized HbA1c target. Again, in the elderly population, not your target of HbA1c is not 6.5. It may be 7 or 7.5, even 8 also. Because if you reach the 6.5 in elderly population, 80 plus, you are inviting hypoglycemia. And this hypoglycemia is much more dangerous. He got fractured femur because of the fall. fall because of the hypoglycemia. Okay, so these are very, very important. In all cases, dehydration, delayed wound healing, and HSS should be avoided. So in elderly population means not DKA, HSS. That is hyperglycemic, hyperosmolar state. More dehydration, more mortality. Treatment of other CV risk factors should also be taken into the consideration. So once the patient is more elderly, so most and more atherosclerotic cardiovascular risk factors will be there. So what are the major atherosclerotic cardiovascular risk factors? One, age is a big risk factor. Smoking, diabetes, hypertension, dyslipidemia, physical inactivity. So these are all. So most of the people, they will have all these things. So that is the reason their atherosclerotic cardiovascular risk will be more than 10%. 47-year-old male, type 2 diabetes for the last 11 years. Very typical Andhra patient. He has come to you with complaints of mild abdominal pain. It's very common. Already must have taken Omes so many tons so far. He doesn't take alcohol. He is a non-smoker. Height is 167 centimeters. So ideal weight is 167 minus 100, 67. But he is 98 kgs. So he is obese. His BMI is 35. Acanthosis nigricans is present that shows signs of insulin resistance. So he is obese, insulin resistance, and diabetic. Abdomen examination, enlarged liver, which is firm, non-tender, with rounded edges. SGOT and SGPT elevated to more than 3 times the upper limit of the normal. So upper limit of normal is 30 to 40. SGPT maximum limit, upper limit is 30 in some labs, 40 in the some labs. So it is almost 3 times. That means 120 SGPT and 120 SGOT. So what is the working diagnosis? So type 2 diabetes, obesity, and fatty liver. It is not because of some infections or not because of the sepsis, because here the liver is non-tender. That you should understand. So tender hepatomegaly means the DDs are different. It could be a malarial hepatomegaly, it may be hepatitis hepatomegaly, or it may be some sepsis hepatomegaly, etc. But it is a non-tender and is a form that shows it is a fatty liver, may be converted to the fibrosis or cirrhosis and etc. So what investigation will confirm the diagnosis? So ultrasound abdomen, not simple ultrasound abdomen. Ultrasound abdomen in reference to your liver, elastography. Now the good ultrasound machines are there that will tell you the liver firmness and liver fatty expression of the liver also. So that is fatty liver. Okay, simple ultrasound abdomen that shows liver is enlarged. Okay, so it's of grade 1 or grade 2 hepatomegaly. But is a hepatic elastography of the ultrasound abdomen that will tell you almost like a fibroscan. Okay. That fibroscan is costing about, value is costing about 3 to 5,000. But your ultrasound abdomen elastography, you can get it for 2,000 or 2,500. So what is the treatment? So there is no specific drug to treat the fatty liver. So treat the underlying conditions and treat the obesity. So reduce the overweight, make him normal weight. And the second one is control the blood sugar very effectively. And as he's a non-smoker and non-alcoholic, continue that. And then dietary restrictions. So less and less fatty diet because he's already 98 kgs and about 35 BMI. So very low saturated fats, increase the polyunsaturated, high fiber diet, low salt, high fruits, that potassium, so good sleep. So these are very, very important. Okay. And if the treatment is there, there is only one drug in India, that's saroglitazar. So saroglitazar, the dose is about 4 milligrams. It is available in the market. The cost is somewhere about 100 rupees. So the only one company is getting it, Zydus. So that is a lipoglyn. Lipoglyn, Lipoglyn. Lipoglyn is saroglitazar, 4 milligrams. So that is the drug. And some people, they write vitamin E. Some people, they write zinc. Some people, they write vitamin C. Some people they write carotene. So some people they use ursodeoxycholic acid, and some people they write Lu-52, etc. So these are all the liver tropic. But the specific drug is mostly a saroglitazar, that is a lipoglip. And you can use the statins here. In some people they use the statin, some people they use the metformin, some people they use the pioglitazone. So these are all the different drugs which may act to reduce your fatty liver. So your metformin, your pioglitazone, your vitamin E, vitamin C, calcium, okay, and magnesium, and then the saroglitazar, your statins. It is also, this is a new term. Now no more fatty liver or no more NAFLD. Now it is MAFLD. What is MAFLD? Metabolic associated fatty liver diseases. Okay. Wide spectrum of the liver diseases. Simple fatty liver is steatosis. Non-alcoholic steatohepatitis. That means a simple fatty liver is a steatosis. Once there is an infection or inflammation, then it will be steatohepatitis. Okay. And then cirrhosis is irreversible. Advanced scarring of the liver. So there will have a fibrosis and the nodule formation. That is the cirrhosis, irreversible one. Two essential features is a non-alcoholic and accumulation of the fat in the liver cells. Now this is the most commonest cause of cirrhosis of the liver all over the world right now. It is not alcoholic hepatitis or viral hepatitis. It is non-alcoholic fatty liver disease or the fatty liver. So all of us, at least 50% of our this group is having fatty liver. Okay, so please understand the pathophysiology of the fatty liver and reduce your oil intake, reduce your saturated fat intake, and more physical activity, at least 60 minutes a day, more vegetable protein. So they are all very helpful for you to become again the normal individuals, because the fatty liver early stages is reversible. But in the latter stages, once it enters into the cirrhotic phase, it is irreversible. Irreversible. I am seeing a lot of cirrhotics right now in my OPD. So background, no history of hepatitis, HbS positive, C negative, etc. and also non-alcoholics. So because of diabetes, because of obesity, because of physical inactivity, because of the faulty food habits. So this is the reason for your fatty liver. So everyone should be very careful about this fatty liver. So what is the definition of this MAFLD? Not NA. Now the recent term is MA, metabolic associated fatty liver disease. It is a hepatic steatosis diagnosed either by histology or imaging with a macrovesicular steatosis more than 5% of the hepatocytes, according to the histological analysis, or by the proton density fat fraction more than 5.6% as assessed by the proton magnetic resonance spectroscopy MRS or quantitative fat water selective MRI with no secondary cause for steatosis. So chala samskrutamlo unnattundi, but one thing is very clear, there is a fat in the liver, the cause is not known. It is not because of the virus, it is not because of the alcohol, it is not because of the something else. So there could be a metabolic cause. So that metabolic cause is a reason for here fatty accumulation in the liver. So more than 5% of the fat in the liver is fatty liver. More than 10% is very high. More than 15-20%, so definitely is going to get cirrhosis and also hepatocellular carcinoma, etc., etc. Esophageal varices, etc. See this spectrum. See, the first one is the fatty liver. So second one is NASH. So fatty liver means simple steatosis. If you add inflammation, steatohepatitis, that is your NASH. And once it is fibrosis, then it is nodule formation, that is the cirrhosis. See the cirrhosis, very thick liver and a very small liver, very contracted liver, like your CKD. So what will happen when the GFR is 15 and 20? If we take an ultrasound abdomen, the kidneys are contracted. There is no corticomedullary differentiation is not seen. So grade 2 or grade 3 medical renal disease. That is a routine ultrasound report you see in the CKD population. So same way here, the kidney, the liver also very dark, new nodule formation, fibrosed, and small in size. See the NAFD. First one is the metabolic associated accumulation of fat in the liver cells with no inflammation. Once inflammation is there, that is NASH, steatohepatitis, or scarring. Once scarring and the NASH means that is progressing. So this is the reversible one. MAFLD. We are all in the stage of MAFLD. They are reversible one. So some of us are in the NASH. What you mean by NASH? Accumulation of fat in the liver cells, that is steatosis, as well as inflammation. So that is hepatitis. So steatohepatitis. Okay. Then some of us will have a fibrosis in the next few years. And some of us will get the cirrhosis after 15 or 20 years, even though we are non-alcoholics, even though we are having HbA1c and HCG negativity. Unless you concentrate in the stage 1. We are all in the stage 1 right now. And some of us will reach a stage of cirrhosis, maybe after 10 years or 15 years or 20 years. So be careful about your livers. So liver is very, very important organ in the body. If you don't take precautions, so definitely we are all going to have a cirrhosis. So it's a progression, disease progression by time, but it takes a lot of years. From MAFL to the NASH, it will take maybe 5 to 10 years. From NASH to the fibrosis, another 5 to 10 years. And fibrosis to cirrhosis, another 5 to 10 years. But our average lifespan right now is 85 years. Suppose if you get the cirrhosis at 70 years or 75 years, so your life will be miserable in the next 5 years or the 10 years. So we should develop the health span rather than the lifespan. Lifespan is different from the health span. Lifespan means you are adding years to your life. Okay, what is health span? Adding life to your years. That is health span. So we have to improve our health span. We should be asymptomatic till our last breath. So this is the MAFLD and the metabolic syndrome. It is one of the hepatic manifestations of the metabolic. I told you in the beginning, metabolic syndrome, you know the 4. Now you add the fatty liver also. One of the basic defects leading to the NAFLD is insulin resistance. Again, what is the basic pathophysiology of the metabolic syndrome? Good. Insulin resistance. So insulin resistance is the cause for diabetes, insulin resistance for hypertension, insulin resistance for dyslipidemia, insulin resistance for obesity. Now the insulin resistance is for fatty. So from tomorrow onwards, whenever you see a diabetic, see the acanthosis nigricans. It's a marker of, so that means it's a potential candidate for fatty liver also. Fatty liver also. That you should understand. So at the background of your thoughts, no, you should always see the acanthosis nigricans in all our people with type 2 diabetes. Not on the nape of the neck. Some people will be having on these folds. Some people they will have the black spots on the forehead, or maybe on the here, on the cheek, or maybe on the buckles. So these are the very, very important places where you should look for acanthosis nigricans. Not only acanthosis nigricans, skin tags. Some people that develop the skin tags also. Some people will be having the abdominal adiposity. Okay, your waist circumference is more than 90 centimeters in the male, more than 80 in the females. So that definitely tells you that you are having more insulin resistance. Your triglyceride levels, if it is more than 150, all of us triglycerides will be 200, 250. Again, that itself shows that we are having insulin resistance. So don't underestimate the value of insulin resistance in your clinical practice. And insulin resistance is directly proportional to all these diseases. So by learning diabetology, you are making the people more healthy. Because on one hand, you are seeing the diabetes, on the other hand, you are seeing the hypertension, and you are seeing the obesity, and you are seeing the dyslipidemia. Now you are seeing the fatty liver. So this is the best course for anyone to practice in India is the diabetology. Okay, I'm happy that you are all going to be very, very good diabetologists in the near future. Not only the diabetologists, but also hepatologists. Hepatologists. So this is the thing. Even if you see the case by DM for hepatology, this fatty liver, what advice is you? What is the drug in his hand? Saroglitazone. For whatever the insulin produced by your body is not capable of pushing the sugar into the glucose, into the muscle, into the adipose tissue. So that is the reason you are producing more and more insulin. So pancreas is producing more and more insulin in the people with insulin resistance. That is called hyperinsulinemia. So even that hyperinsulinemia is not sufficient to cause euglycemia. Insulin resistance means physical activity. Insulin resistance means dietary approach. Insulin resistance means sleep, good sleep. Insulin resistance means very low alcohol. Insulin resistance means no smoking. So this is insulin resistance. So most frequent risk factor for insulin resistance is obesity, especially abdominal obesity. So how many percentage of us are having abdominal adiposity? 99.9%. See the normal NASH and then the gene and cirrhosis. So this is the pathophysiology of the fatty liver. Hepatic insulin resistance, that means more gluconeogenesis, exaggerated lipogenesis, inflammation. Muscle insulin resistance, abnormalities, the myosin levels. So there is hyperinsulinemia. So satiety preference and appetite, etc. Over nutrition, fructose and sucrose. So they are all over nutrition. Leaky gut by taking more and more curd, fermented rice with curd. So these are all very, very good. Curd is very good for health. Very good health. NAFLD magnitude, the most common cause for abdominal liver function test. 10 to 25% of the population. I don't think that it's not 10 to 25%, maybe 25 to 50% of the population, especially the adults. Very common, very common. I asked 55 to 75% of the obese population. Obese population, not 55 to 75, maybe 75 to 95. 2.6% of the children, not 2.6, maybe 15 to 20% of the children. Okay? See, 25 to 30% of the obese children. So that may be the right. But all 5 figures, we have to increase it by doubling or tripling. 17 to 32% of the urban population in South India and 55 to 87% of those with the diabetes have been shown to have the MAFLD, metabolic associated fatty liver disease. A recent meta-analysis suggests that 1 in 3 adults and children in India has NAFLD. But in our Godavari districts, maybe 1 in 2 adults, or maybe 2 out of 3 adults. So that common NAFLD. Okay. See, this is the global button. See the US button, 51.8%, whereas in South Asia, more than Western population, it is 55.9%, whereas in India, maybe 70%. Okay. High risk groups, males more than the females. I think females equal, both males and the females. Individuals with the diabetes are having. People with dyslipidemia, abdominal adiposity, obese children, weight more than 95% for age and the sex. DD of the fatty liver, macrovascular steatosis and microvascular steatosis. Macrovascular, significant alcohol consumption, viral hepatitis, some drugs. We are using the methotrexate for our rheumatoid arthritis, so that may damage the liver. Amiodarone, we use it as a cardiac arrhythmic drug. Tamoxifen, so that when we use it in the carcinoma of breast. CGTS, hemochromatosis, autoimmune hepatitis, celiac disease, Wilson's, lipoatrophy, starvation, parental nutrition. So these are the different reasons for the fatty liver. And microvascular, race, medications like sodium valproate, ART, again international capital of HIV is India. So a lot of the people are on heart. They are doing very good. Now the HIV is no more a killer. It is almost like a chronic disease of your diabetes and hypertension. So they are 90% of the obese is the right one. 35 to 40, 50% of acanthosis nigricans. Enlarged liver, which is usually non-tender, but maybe associated with the dragging sensation of the upper abdomen. When the liver is palpated, it usually feels normal. When very large amounts of the fat accumulates in the liver, it can become quite large with a soft, rounded edge, which can be easily felt. Other comorbidities, so see the sleep apnea. Of course, metabolic syndrome comorbidities, no sleep apnea. Steatosis, ultrasound is the preferred first-line investigation in primary care, very easily available. MR is the gold standard, but more expensive and less available. If imaging is not available, scoring systems such as fatty liver index, steatosis test, or liver fat score can be used, that is your fibroscan. Non-alcoholic fatty liver disease, can reliably distinguish the NASH from the steatosis. Biopsy is required to know whether the inflammation is there or not. Biomarkers and scores of fibrosis along with elastography are acceptable non-invasive tests in patients at low risk of progression to the cirrhosis and fibrosis. So this is available in some radiology centers. Elastography of your liver. Scoring systems, fibrosis score, FIB4, fibrometer, fibrotest, ELF test. These tests are not as reliable in advanced fibrosis and cirrhosis and need confirmation by the liver biopsy. So when the cirrhosis means it's almost like a histological diagnosis. So on the scanning, we can't say whether it is a fatty liver or steatohepatitis or the fibrosis, etc. Of course, a full-fledged cirrhosis, so definitely the liver size will be reduced. It's very thick in size, and there will be the ascites, and there will be the so there will be gynecomastia, there will be the pedal edema. So definitely we can say clinically a cirrhosis, and we can coincide with the. Otherwise, when you are in a doubt, so definitely the biopsy will clinch the diagnosis. Liver biopsy. So this is the ABDA score. Utilizes what is ABDA? A stands for AS, B stands for BMI, D stands for diabetes, and A stands for your ALT levels. So very simple score. So with this score, you can diagnose the fatty liver even without ultrasound also. AS, more obese, presence of the diabetes, and SGPT, SGOT levels are elevated. That score more than 3.52 identified fibrotic NASH and 88.9% sensitivity and 88.3% specificity. So this score more than 3.52. Okay. Liver biopsy. So this is the steatosis, this is the fibrosis. Diagnostic algorithm. In all cases, exclude secondary causes of the fatty liver. As I told you, in a viral hepatitis, alcoholic hepatitis, Wilson's disease, hemochromatosis, or the drug therapy like amiodarone or methotrexate or sodium valproate or tricyclic antidepressants. So these are the other causes of the fatty liver. Exclude all of them. Ultrasound. Steatosis biomarkers, liver enzymes. Steatosis present. Normal liver enzymes. Serum fibrosis markers, low risk liver enzymes. Abnormal liver enzymes. Identify other chronic diseases. Normal liver enzymes, the follow-up. So this is the very common. So ultrasound, and then the two things very common. As a diabetologist, you all can advise ultrasound, can get the SGPT, SGOT. Along age, the patient will tell you. Diabetes, all of you people reach you or the diabetics, and then see the obesity. Your acanthosis nigricans, abdominal adiposity, or waist circumference, etc. And then act accordingly. Treatment options, lifestyle modification, just 5 to 10% weight loss can cause 25% regression of the steatosis 1 year. So suppose you are 80 kgs. So reduce by 5 to 10%. That means 4 to 8 kgs weight loss can be done. Now we can afford, all of us can afford a Monjaro. Or some of you with the diabetics, then you can go the Wegovy. That is injectable semaglutide. Of course, oral semaglutide is available. That is a Rybelsus. We have to use in the dosage of 3 milligrams in the first 1 month with half glass of the water on the empty stomach. And the second month, we can go up to the 3 mg to the 7 milligrams. On the third month, 14 milligrams. But most of my patients, they are happy with the 7 mg. Because a few side effects are there, mostly the gastrointestinal side effects. Nausea, vomiting, abdominal cramps, loose motions, etc. And some people, they may not appreciate, they may not continue the drug therapy because of these side effects, and they will respect their feelings and they stop taking the Rybelsus. But 80% of the population, they can continue the Rybelsus and they are all very happy till last 2 months. But now we have the 2 injectable drugs to reduce our body weight. One is Mounjaro, that is a terzepatide, that is a dual agonist. Your GLP-1 and GAP agonist. That is a terzepatide. Now available in the dosage of 2.5 milligrams, 5 milligrams, 7.5 milligrams, and then the 1 milligram. Okay, now see the vitamin E. Not much role. Metformin, good. Pioglitazone, good. GLP-1 receptor agonists are good. SGLT-inhibitors are good. They are all doing very writing left and right for our patients. And statins are also good. So out of them, The most important is the lifestyle interventions. Vitamin E plus or minus, all are useful. Now move on to the oral problems. So the diabetes and the oral problems are very common in the diabetes. Relationship between the dental problems and the diabetes is bidirectional. See the bidirectional. Dry mouth, autonomic neuropathy, or reduced immunity, poor diabetes control, dental disease, inability to comply with the diet due to the pain or lost teeth infection. So all these years we thought that the dental is totally different from us. So now that there is a good relation between the dental and our diabetes. Okay. So common oral problems in the diabetes: gingivitis, periodontitis, oral thrush, xerostomia, dry mouth because of the autonomic dysfunction, and dental caries. These are all very common in our practice. That is the reason the torchlight should be there in your on your table. So as and when required, you have to open the mouth and see for these things. For any gingivitis, periodontitis, oral thrush, xerostomia, dental caries, they are all spotters. Once you open the mouth and see it, okay, you don't require any investigations, costly investigations to detect all these things. Look for these diseases with unexplained deterioration of the glycemic control. Why? The sugars are very high. He is having these oral problems. So unless you control these oral problems and the diabetes is all direct, like bidirectional. Now the travel and the diabetes. So ensure the good glycemic control beforehand, can carry adequate supplies of the medication, carry your identity card saying that you are a diabetic, carry adequate supplies of the easily absorbed carbohydrate like any sugar, etc., to avoid unforeseen hypoglycemias. This is a very important during the travels. Here a 56-year-old businessman with type 2 diabetes traveling non-stop from Mumbai to New York. He will leave from Mumbai at 12:20 a.m. midnight and reach the New York by 11:15 a.m. New York time. Okay. So our time is here, it is only 11 hours. Okay. But their time is different. He wants to know how he can administer his insulin shots while traveling so as to reduce the risk of both hypo and hyperglycemia. He is presently on injection regular insulin 3 times daily before the meals and injection of NPH insulin once daily before the dinner. That is like our Gunavati's father, 4 shots a day. So what advice will you give him? He is moving from Mumbai to New York. So what is your advice? He is carrying our insulin syringe in the pocket. So regular insulin syringe is there in the pocket, and also the long-acting insulin like your Glargine or your Detenec is also in the pocket. What advice you will give? So this is the answer. Suppose traveling to the east, if they shortened by 8 hours, so reduce the pre-flight dose. First dose post-flight at usual clock time, new time zone. So avoid the regular insulin when the day is shortened, and then take the regular insulin at the destination times. Suppose the day is lengthened by the 8 hours, give additional insulin in the flight. First dose post flight at the usual clock time. There is a new time zone. So that is very clear, but don't bother about these timings and etc. So when the fellows are moving east or the west, you have to do some adjustments in the insulin. So the best insulin for them is the regular insulin. So don't give him insulin before the flight time. So give the insulin at their destination time, according to the destination time. If the day is prolonged, you can give the regular insulin in the flight itself, while taking the snacks or the food. So can a person with a diabetes drive? That is important reason for our accidents, because most of the young fellows are diabetics and these people are doing driving on the road. So our individuals with diabetes are at a high risk of driving accidents. Type 1 diabetes, yes, because of the retinopathy, because of the neuropathy. So a lot of the problems will be there. In the type 2 diabetes, no increased risk even if they are on the insulin. So the more risk is with the type 1 diabetes. So recent studies show that individuals with the tight control of the diabetes have higher risk of road traffic accidents. Due to hypoglycemia from the treatment used to achieve the type 1 diabetes is the increased risk. Recent studies show that individuals with tight control of the diabetes have higher risk of road traffic accidents due to hypoglycemia from the treatment used to achieve the tight control. Important. So hypoglycemia, visual impairment, lower extremity complications like peripheral neuropathy, amputations, vehicle can be suitably modified to overcome these. And driving, blood glucose levels below 70 mg can impair the driving performance. At this level, the patient may not even realize that he has hypoglycemia. So the patient may not realize that he has hypoglycemia, impaired judgment, reduced insight, irrational and impulsive behavior, mood changes, irritability and anger. Hypoglycemia can itself impair the vision. So hypoglycemia unawareness is particularly very, very dangerous. So all the type 1 diabetics, so always better not to give steering for him when they are going on the highways. A person with diabetes should not drive if newly diagnosed and yet to under control, and recurrent daytime hypoglycemia, hypoglycemia unawareness, reduced vision, severe neuropathy, severe peripheral vascular disease, lower limb has been amputated, can drive suitably modified the vehicles. So here a female diabetes for the last 15 years. She consults you once in 3 months. So she is very regular. Complaints is good. Last consultation was 15 days ago. At that time, her blood glucose was under very good control with A1C 6.8%. Excellent. Her blood pressure was normal. Good. She is on insulin and OHA. She calls you from her home. She tells you that she is suffering from fever with occasional vomitings. Fever with vomitings. She is not able to eat her usual diet. She wants to know what diet she can take and should she continue her usual medications. She also tells you that she is living far away and will not be able to come for immediate consultation. Okay. So what advice will you give her over the phone? So this is very, very important. So a lot of the people, the diabetics with fever, with vomitings, she is on OHA and also the insulin therapy and away from the for your place. So what advice? What sort of diabetes education will you give to her when she comes to see you next time? So that means diabetes in for sick people who are residing away from your chambers. So there are all the sick day rules. Test the blood glucose more often. So for all these population, when the fellow is on the insulin therapy, always a glucometer must be there. Always advise a glucometer which is costing about 600 to 800 rupees today. Do not omit the medication. Test the ketones. First test the blood sugar. If the blood sugar is very high, test the ketone bodies. Hospital is unable to tolerate the water intake. So whether you are from 50 kilometers or 70 kilometers or 80 kilometers from here, suppose you are around somewhere at the near Rajolu, so reach Gunavati. Somewhere around Piduralla, reach these two fellows. So these are the very important. So advise hospitalization when the fellows blood sugars are very high, when the fellow is dehydrated. So dehydrated means they are going into ketoacidosis. 70-year-old lady with type 2 diabetes wishes to observe a dawn to dusk fast for religious reasons. That's the Ramadan. She is on top glycoside 80 mg twice daily, morning and the evening. And metformin 500 milligrams twice daily, morning and the night. Acarbose 25 milligrams 3 times a day. So what will you advise her regarding her medication? So daytime they don't take anything. So no acarbose. Okay. So morning and the night. So morning you can continue glycoside and the metformin, and night you can continue glycoside and the metformin. But morning if you give the high dose of the glycoside, if you develop the hypoglycemia, so again they can't eat it. So better not to use hypoglycemic agents in the morning time. Even in the night time, if you use the hypoglycemic agents, at 8 o'clock, if you give hypoglycemic like sulfonylurea, even if you get the hypoglycemic at 12 night or 1 night, you will take something because night time they can take anything. Daytime they should not take. So don't give hypoglycemic agents in the daytime. So any insulin, you can reduce the dose. Sulfonylureas, reduce the dose or stop using the sulfonylureas. That is the advice you should give. So now move on to the rheumatological problems. So with this I stop. So limited joint mobility, common in type 1 diabetes and less so in the long-standing type 2 diabetes. Involves the small joints of the hands. It is also called as geroarthropathy. Can involve the foot, which can lead to deformity like attex rigidus and increase the risk for the ulceration. There is a motor neuropathy, mainly due to the microvascular disease or glycosylation of the collagen. Also is the nephropathy and the retinopathies. Thickening and the tightening of the skin, that is called pseudoscleroderma. Starts from the ulnar side of the hand and spreads radially. can cause difficulty in using the insulin syringes and the glucose blockers because their hands will be very tight. So trigger finger, Dupuytren's contractures, etc., etc. So this is called limited joint mobility. This is a very common in uncontrolled diabetic individuals. See here, they can't approximate these both the hands. Okay, so prayer sign is a positive, no specific treatment. Physiotherapy can give some symptomatic relief. All those reductase inhibitors have been tried experimentally with the mixed results, like ALA, etc. It is a marker for microvascular disease. It's a marker for microvascular disease. That is like nephropathy or retinopathy, etc. Again, microvascular disease is a marker for your macrovascular disease. Your proteinuria is a risk factor for your vasculopathy also. See, this is the Dupuytren's contracture, found in both type 1 and type 2, more common in the elderly individuals, milder than in the patients without the diabetes. Usually involves the middle and the ring fingers. Management physiotherapy, sometimes we can give the steroid injection. So this is also very common, trigger finger. Intermittent locking, common in diabetes of long duration, associated with the cheroarthropathy, response to the steroid injections at the base of this finger. If you give a steroid injection, that works better. This is so common, adhesive capsulitis. Pain and limitation of the movement of the shoulder. Most commonly, external rotation of the abduction is affected. So front side activity is sometimes very good, but the back side abduction and external rotation will be very much limited. It is also called the frozen shoulder. 10% of the patients with the diabetes, more likely to be recurrent, and some people will be bilateral also, associated with the retinopathy, etc. See, all the rheumatological problems, even though they look like the rheumatological, these people are background, they are more prone for the microvascular and macrovascular complications.